Got it. Thank you.
Lots of background noise, yeah?
Okay, maybe we have everyone here. Hi, Catherine.
Hi.
All right, so I am going to do a quick roll call. Catherine is here.
I'm here.
Rhonda Johnson is going to join us audio. Jeff,
Here.
Melissa,
Here.
Lisa,
Here.
Jennifer,
Here.
Senator Yuko, Diane,
Here.
and Beverly.
Here.
All right. And Alex, you're here. So now or Catherine, do you want to get the approval of the minutes from the last meeting?
Yeah, I sent those out in advance. Sorry, getting a lot of feedback here. Sent those out in advance. And do I have a motion to approve?
Here.
So moved.
I'm sorry, I didn't hear who said that.
Doug Beach.
Thanks, Doug. And a second?
Second.
Oh, okay.
And that was,
Jennifer.
thanks, Jen. I was looking down and not seeing who said it. All right. And so that motion is to approve the minutes without correction. All in favor?
Hi.
Aye.
Any opposed? All right. So the minutes are approved as submitted.
Thank you.
Pam, Senator Yuko just joined, and we have a couple of guests with us already.
Thank you. Today's meeting, we have 3 guests joining us, and Alex is going to introduce them. And I'm very excited for us to learn additional information to help our committee move forward. And with that said, Eric, Alex, if you want to go ahead and introduce our first speaker.
Absolutely. Thank you, Pam.
Terrence Black.
And so I think our first speaker needs no introduction. He is very well known in the aging and long-term care space.
Campground.
His name is Dr. Bob Applebaum, and he is with the Scripps Gerontology Center at Miami University of Ohio. He is the director of the, let me just make sure I get this right, the director of Ohio Long-Term Care Research Project. And he's also a professor at Miami University in the Department of Sociology and Gerontology. And so without further ado, Dr. Applebaum, thank you so much for joining us.
My pleasure. Thanks, Alex. I'm wondering, can I share my screen?
Sure.
How do I, you have to give me, let's see. Do you have to give me permission? I'm not seeing anything that lets me.
You don't see an up arrow next to the leave button?
There's a more, let's see.
I'll check and see.
Okay, wait a second. I got something now. Hold on. Can you guys see anything?
I do. Yes.
Yes.
Awesome. Okay. Thank you. Thank you, Bev. Alrighty. So I talk with with a few folks, and I tried to put together something that I thought would be useful, but I really want this to be more of an opportunity for you to just ask questions as I go through. So I'm going to give you some data as I try to frame this for the kind of work that you guys are doing, but really I hope this is more of a dialogue about any questions that you all have as opposed to me just talking to you. So let's make this as flexible as possible. I know the Zoom world is a little bit difficult in these days, but we'll give it a try. So I just want to start by showing you some numbers that you've already seen a gazillion times out for 2030 and 2040, but I'm doing this for a reason when it comes to dealing with the Alzheimer's challenges or the dementia challenges that we're going to face as a state and as a nation. So you can see here that basically Ohio's population growth overall is almost non-existent. It's very flat, way less than 1%. And you see our 60 plus group goes up between 2020 and 2030, then it actually goes back down because the baby boomers have then reached 60 and gone over the other side. You see for the 65 plus group, we between now and 2030, we jump by about 19%, but then we drop there. But you look at the 80 to 84 group, and that's going to jump between now and 2030, just 10 years, by 36%. And then if you follow that down, the 85 plus group is the big jump is 34% in 2040. So the big jump groups are the 80 plus population, and I'm going to come back and talk about that in a minute, but that's what we look like as a state when it comes to our population growth. So obviously when it comes to a lot of economic issues, when it comes to Medicaid, these are not the data that you necessarily love to see because it means our population base is flat, but we're getting a lot older, and with that there's increased costs along the way. So and all other issues as well. The other thing I just want to remind folks about, which again we know, is that aging definitely, and particularly when it comes to aging services, this is very much an issue that impacts women more than it impacts men. If you look at this slide, what you see is that when you get to the 85 and over population, and remember, I just showed you the growth in that population, particularly in 2030 and 2040, we see that only about 14% of women age 85 and older are actually continue to be married, where it's men, it's almost 60%. And that's, of course, because women have more life expectancy, and because in American society, in traditional heterosexual couples, women tend to marry older men. My women friends tell me this is because men are immature and they have to go up the ladder in order to be able to have a relationship. I'm not going to get into that, but the fact of the matter is that what this means is that you got a growing 80 plus population. You've got the fact that women are more likely to be by themselves in that age. And then when I show you some of the dementia data, there's another factor, which is the prevalence rate is higher for women. So all that together means that our challenges are going to continue to rise. So these are some data for Ohio on first the population, which is everybody, and then females and males. If you look at the prevalence, this is no surprise that the prevalence rate for dementias of all kinds goes up with age. So in the 65 to 74 group, we're talking about 3.6%, but it goes up, and by 85 plus, the prevalence rate is almost 35%. So we do know that this population, particularly the 80 and 85 plus population, is much more susceptible to dementia and related disorders of any type. And then if you look at the issue by race, what you see is that we do also see racial differences where non-white Hispanic population, even at 85 plus, is at still high at 34%, but African Americans at 43% and Hispanics at 40%. So we see here that we begin to see groups of folks, 85-year-old women and women of color in particular, who are going to be affected by this even greater than the general population. So again, as you're thinking about your response to these challenges, these are the kinds of demographic things that I would want people to think about as we move forward. I'm going to stop there for a second, just because I've thrown out a lot of numbers to give anybody an opportunity to ask questions or to make comments before I go forward.
Bob, it's Catherine. The prevalence of Alzheimer's disease and related dementia, that the total number that you have at the bottom, so that 10.9 reflects what?
Okay, so that's if you take the entire 65 plus population, the prevalence is estimated at 10.9%. That's a snapshot.
I
So
see, of
that's
the entire population.
the
Got
entire 65 plus population. And then you can see here that the prevalence rate for women at 12.2% is certainly higher than the prevalence rate for men. And then the prevalence rate, again, as you see, for African Americans and the prevalence rate by age group, again, higher.
Got it. Thank you.
Dr. Applebaum, this is Jen Blau. Do you have statistics regarding this population in living in long-term care facilities versus living at home?
We do, and I'll actually share with you a couple of slides from our data on nursing homes. And as a matter of fact, let me go. That's a great segue to the next slide, which is, and this is a little out of date because we're a little bit behind on our longitudinal work that we've been doing for the Department of Aging for the last 25 years, where we track utilization. But because of COVID, we didn't go out into the field with our survey until just about a month ago. But so this is for 2017. It's a little bit dated, but essentially what this shows you is if you take a look at everybody with severe disability who's over the age of 60. Now, this includes both physical disability and cognitive disability, and I'll show you some more data that breaks that down. But what you see here is that everybody with physical and cognitive disability, and these are severe, so these are people who meet nursing home level of care. And what you see here is a couple of things that I think are really interesting. One is that most people, even people with severe disability who meet nursing home level of care, are not living in nursing homes. If you take a look at the Medicaid number of 17% and the private pay rate, we're seeing that less than 22% of everybody who's over age 60 with severe disability actually lives in a nursing home. Another quarter of those folks are in either the passport waiver program, the traditional, or my care. We do see that the biggest slice of the pie are people who are getting care from their family or paying privately. And I do think as your committee thinks about the work that you're doing, this is a large chunk of people, and the pressure on those folks, as we all know, is mounting by the second. And so I think how we respond to support those folks going forward is going to be absolutely crucial. Then the rest of the pie are RCFs or the Aging Service Levy programs, or even Ohio's prisons, which do still have some folks who are severely impaired as well. So it's a range of places, but I think that, as we all know, families, we sort of have this view that families aren't doing it the way they used to back on Walton's Mountain. But the fact is that families have provided more care today than they ever have in our history. It's just that we have more people that need that care. So I'll show you a couple other slides as I go through here that will show you a little bit about where folks are and what they look like when it comes to setting. So I'll answer that a little bit more as I go through this. Okay.
Hey, Bob, this is Doug Beach. Just a real quick question. I don't have a feel for how many of these women are widowed. And we know for those that aren't widowed, they get their own Social Security, and it's about $10,000 less than a man. Do we have those types of numbers here?
We have some. We don't. What we know is, I'm going to jump around a little bit here just because so what we know, for example, is that if we look at the nursing home population, which interestingly has changed because, it's hard to wrap our hands around the world of long-term services because it's such a dramatically changing world. And so it used to be, when I was in graduate school, the first book I ever read was called Last Home for the Aged. And there was an assumption that you went to a nursing home and that's where you live the rest of your life. Well, now nursing homes are serving two very distinct populations. So they're serving people who are going for rehab for short-term care, and then they're serving people with long-term care. So if you will, Doug, to your question, if you look at the slide, you see that since 96 to 16, what we saw is fewer females living in nursing homes. But that's primarily driven by the short-term increase. And if I showed you data for people who lived in nursing homes longer than a year, or even longer than 100 days, it's going to be much more likely to be women. So it's sort of when you lump them all together, it looks funny. So you see that nursing homes are serving more people that are married, more people that are men. But that's because of the short-term, long-term mix. And so I would say if you look at the long-term side of things, it's going to be women because they live longer. And there are indeed economic issues, as you suggest, because as we know under Social Security, you might have two people earning income or getting Social Security, but when one spouse dies, typically the man, then they get the higher of the two benefits, but not both, to your point. So I think absolutely, and that makes certainly people more susceptible to sort of challenges with all the kinds of things that we know about. Absolutely. And I'll show you, if you look at, this is, sorry to jump around, but if you look at some of these issues for who's in assisted living waiver, it's primarily women. I don't have that on this slide, unfortunately, but it's primarily women. If you look at passport, it's still primarily women. So, and if you look at nursing homes, it's still primarily women. And again, part of that is because of the women. And then when they die, they don't have it. So I think that the gender issue is certainly important, and it does interact with both the economic side of things and the prevalence issue. So absolutely. I think I might see a hand up on. Did somebody have another question? I thought I saw a hand up, and that may have been one of you guys that asked.
Yeah, I lowered it. Sorry.
Okay. Any other questions? I'm going to jump back here quickly.
Hey, Bob, this is Kenny Yuko. Can I ask one fast question?
Sure.
With the prison population, what happens to our inmates when they get diagnosed with Alzheimer's or dementia?
In most cases, they're just cared for in prisons. There have been, a rare number of cases where people have gotten out, but in most cases, they kind of remain. And so, the Hocking prison has been the prison that's been the most common prison to serve older prisoners. But there have been a couple of proposals from the legislature to try and figure out a way to send those folks to some kind of nursing home setting to be able to provide care in that. But obviously it's challenging because you don't necessarily want to put them in a regular nursing home. And but as life is tough in prison, and so people age faster, and so there are people with some fairly substantial disabilities that are living in Ohio prisons.
Okay, thank you.
Okay, so I just wanted to show you quickly, this is the nursing home facility occupancy rates, and these were pre-pandemic. And the reason why I'm showing you this is because Ohio's nursing homes have changed dramatically since the 1990s, where you can see, if you follow, there's two things that I would want you to follow. One is Medicare admissions, which went from 30,000 in 1992 to 147,000 in 2017. So what you saw here was a completely different industry. It was an industry that now is serving a lot of people in short-term care. And then you also saw an industry that dropped from 92% occupancy to 81% occupancy. This is pre-pandemic. And basically what you saw here was the change of Ohio's system from one that was really driven by nursing homes to one that provided a lot more home and community-based services and a lot more care and assisted living. What I'm going to tell you is that today, the occupancy rates in Ohio nursing homes, rather than being at 81%, are now at 71%. Now, this is a pandemic function for two reasons. One is because people are not doing some of the short-term elective surgery, so some of the Medicare admissions are dropped, and you're also seeing a drop in even long-term admissions. I think this will change. The trend was down, but I think this will change as the vaccine has come out and as families begin to go back to work. But again, I wanted you just to have the context of, we are in a dizzying, changing world, and nursing homes are really struggling right now, and I think are going to continue, as are AALs to some extent. I already mentioned this issue about sort of the changing nature, but to the question earlier, if you look at the final piece of data here, about this was from 2016, we estimated that about half of the Medicaid residents were cognitively impaired. So that was the question from earlier. I'd say it's probably higher now. And in my view, the nursing home of the future is going to be almost entirely people with memory care issues or people who are doing short-term rehab. I think the person with physical disability is going to be getting cared either at home or in assisted living. They're not going to be living in nursing homes in the future. So I think the issues surrounding memory care and people with Alzheimer's and related disorders are going to grow in the institutional settings for sure. And I think, again, that's something that I wanted to call your attention to your committee, because I think that's something that you certainly need to think about. Just wanted to quickly say that residential care facilities are growing, and this is primarily in the area of assisted living. Remember, this is an industry that 25 years ago barely existed. When we did our first study in 1992, Ohio had 8,000 RCF beds. 8,000. You can see here in 17, we had almost 57,000 beds, and that number is even higher now. So you've seen an industry that's come out of nowhere. They do serve a fair number of folks in memory care as well. In fact, when we did our memory care study last time, we found there were more designated memory care units in assisted living than there were in nursing homes. So about 35% of assisted living facilities are reporting having separate memory care units. These are just data from the assisted living waiver, and you can see here that about 1 in 5 AL waiver residents are reporting requiring 24-hour supervision. So again, trying to think about where people are who have cognitive impairment. We got a chunk of those folks living in the assisted living waiver, but I'll also call to your attention that we get a lot of pushback from the AL residences who are saying that the rate for memory care people is so low that they can't serve them adequately. And so, in fact, one of the things we're seeing is that the rate of termination to nursing homes from AL is higher than the rate from Passport. You would think that people would be able to stay in the ALs longer, but it's not the case, and some of that may be incentivized to get people out because the rate is too low. Jennifer, do I see you have a question?
Yes, thank you. Can you tell us how Ohio stacks up to other states in the country?
On
just generally in terms of our demographics, our number of people in assisted living facilities or long-term care.
Okay, so Ohio has this 6th largest older population in America, so we're a big state. We have a pretty high supply of nursing home beds. We rank in the top 5 in our beds per capita. So Ohio had traditionally relied very heavily on nursing homes and had a strong nursing home industry. But that has changed in the sense that we've really rebalanced. And so, in fact, let me show you. This is Ohio's 60 plus balancing of our number of people on Medicaid age 60 and over and where they're being served. And you can see here in 1993, 9 out of 10 older people with disability were served in Ohio nursing homes. And in 2017, we served 55% of those in HCBS. So Ohio has dramatically changed how it delivers long-term services. We now rank right in the middle. When we first started doing this, we were ranked 47th in our HCBS services. Last year, the AARP does a long-term services scorecard, and Ohio, which had been ranked at the bottom in the first scorecard, Ohio was ranked 19th out of 50, with 1 being the best. So this is a success story that a lot of people don't necessarily know about Ohio, but we have dramatically improved our delivery system, and it has been recognized outside our assisted living industry. Our waiver serves about 5,000 people every day, and we have one of the larger assisted living waivers. Our reimbursement rate is probably lower. It really, the reimbursement rate initially set in 2008 has really been unchanged in its 2020. So we're getting criticism certainly on that front, but in general, Ohio has really progressed quite well when it comes to changing how it delivers long-term services.
Thank you.
Bev, I think I see your hand up.
Yeah, just a comment for the group and then a question for you, Bob. Comment with regard to the statement about residential care facilities and memory care units and people going to nursing homes. I just want to make sure the group understands that staffing requirements are different for residential care facilities. So there's not a requirement for a nurse all the time. There's not a requirement for a state-tested nursing assistant. So the transfer to nursing homes may be in part because the RCFs don't have the staff equipped to, or the requirements, the regulation to equip them. And then question for you, what is the source and the time period for the 71% occupancy number?
That comes The time frame is, I think it was 2 weeks ago, and that comes from our CMS processing of one of our projects is processing CMS data on COVID, and it comes from our processing of our CMS data.
So it's an average over what period of time?
It's a snapshot. It was a
Oh, okay.
snapshot for whenever we did it.
Oh, okay, great, thanks.
Yeah, because this is Doug Beach. We just recently heard that those numbers were 88% before COVID, dropped down 25% to 63% during COVID.
And again, our data that we came from our study, last time we did it was 81%, and those are very accurate data because that comes from our survey of nursing homes, and we back out bed hold days and beds out of service and that kind of stuff. And the 71% data are quite accurate because they come from our tracking of CMS data. So, but again, it could have gone down even lower.
I would trust your numbers better than mine. So,
yeah, but Doug, to your point, during the shutdown in March, particularly when hospitals stopped doing elective surgeries, the Medicare business really dropped out of the nursing home census, and that's where they took a big hit. And so it could have been that low during that time period. Obviously now the Medicare business has come back a little bit, but again, a lot of people, because of the concern about the contagiousness of COVID, a lot of people, instead of going to nursing home for rehabs, were going home. And so this has been a very challenging time. And by the way, in our work, we looked at COVID prevalence in Ohio nursing homes, and in our research, we really found that the biggest factor of having COVID in an Ohio nursing home was community spread. And so if you had a high community rate in your area, then you had a nursing home with a higher rate of COVID. And we actually looked at it. We compared 1-star facilities and 5-star facilities, and we found no difference in prevalence rates between those. So that may have changed now. We haven't looked at that in a few months, but this is obviously, and I will say that the vaccine has dropped the infection rate and the death rate dramatically in Ohio. So that was a place where I think the vaccination of residents has had a huge impact. And if anybody interested in this, if you go to AARP PPI COVID dashboard, we post numbers every month from CMS. And I know I'm probably running out of time, but let me just show you this last slide, which is really the ideas that I think you guys ought to think about. And that is, I believe that the dementia population is probably the biggest LTSS challenge the state's going to face, because the fact is that if you're a family caregiver, when your person requires supervision all the time, it makes caring for at home really difficult. People do it, but it faces a lot of stress on families. And if you look at the increases, if you look at the numbers I showed you on the 80 plus and 85 plus population, and if you look at women, and if you look at people of color and their prevalence rates, those are all pretty scary numbers. We do have a short-term window, if you will. If you think about, the baby boomers starting in 46 and going to 60 or 64 in terms of their birth years, then, we've got a little bit of time, but not very long to figure this out before things get really bad. One of the things research has shown is that health factors like high blood pressure and diabetes and some of the lifestyle issues all impact prevalence. And so it's not just thinking about this outside of long-term care, it's also got to be linked to healthcare. We don't understand a lot about this, but we do know that prevalence is related to health. And then I'll just call your attention to the fact that, we just don't do a very good job of designing the system. A lot of this long-term care system just happened. We didn't plan on it. Medicaid wasn't even supposed to be the major payer, and look where it's happened now. I think that hospitals changed their reimbursement, and that put a lot of pressure on nursing homes to be different places. We have questions about technology and how we're going to move forward, that we need to think about. And then finally, I'm very concerned that the system is completely Medicaid driven. I often say that 90% of Ohioans over the age of 65 are not on Medicaid, but yet everything we do is about Medicaid policy. And I think we're going to need to think about how can we keep people from ending up on Medicaid. If you look at Ohio's numbers today, about half of severely disabled people who are over age 65 are on Medicaid. We're going to double that number between now and 2040. And if it's still half, then we're going to have big trouble. So the question is, what can we do so people don't end up on Medicaid? And I'll give you one small example. A number of Ohio counties have levies, and those levies operated by the county do a lot of great things. But those levies, as soon as somebody can be transferred to Passport, even if they don't need to go to Passport, even if they don't need as much care as Passport provides, the county is going to push them into Passport because they don't want to spend county money. That doesn't make any sense at all. And so what can the state do to incentivize counties to keep people and serve them longer? That's just one small example, but those are the kinds of things that I think we need to think about as we move forward, because we need a rational system, not one that shifts people across sectors just because of funding mechanisms. So I'll stop there, and I see, Melissa, you have a question, and I'm going to stop sharing my screen and take any other questions folks have. So.
Thank you.
Hi, thank you so much for this information. It's so informative. One of the questions I had was, is there a gold standard? Like, is there a state or a program that you think has good qualities that we could look to as we, formulate our plan?
Kind of yes and no. And here's what I mean by that. There's certainly been states that have been leaders in thinking about how to structure their long-term services and support system. Oregon and Washington have been identified as leaders who really transformed their systems long before most of the other states. But it also is the case that Oregon has 7,000 nursing home beds. Ohio has 92,000. And I will say that what works in Oregon probably isn't going to work in Ohio. Every state has their unique structure and unique elements. So certainly there are some principles, and I mentioned this LTSS scorecard. AARP puts out what they call the Long-Term Services and Support Scorecard, and you can go to the AARP Public Policy Institute website, and you can see the most recent scorecard. I'm on a technical advisory panel for what the measures should be, but I don't have anything to do with the scoring. But if you look at the states that score in the top 10, and as I said, Ohio's in the second quartile, but the states in the top 10, they do a pretty good job with choice, with access, but every state is a little bit different. And so I wouldn't want to say Ohio should look like Oregon, because we're just different. Oregon has used, one of the things that Oregon has done to address the population that you guys are focused on is developed a lot of adult foster care. So they have people with dementia who are living with families of, and they might be taking in 3, 4, 5 people into their home, and that might work in Oregon. It kind of scares me for Ohio. We're a big state. I don't know what would happen if we did that. So I think that every state has lessons, but I don't know that there's a state that works perfectly. One of the things I do know is that most of us as individuals are not prepared to be disabled. About 4% of Ohioans have private long-term care insurance. Most of us can imagine that we'll probably die someday, but none of us can imagine that someday we might be severely disabled. So we don't plan for it. And if you don't plan for it, it's probably not going to be a good answer to the story. And so, and it's just hard for people to imagine themselves being disabled. And so we just don't do a good job of that. And we don't do a great job at the state level, and we don't do a great job at the individual level. But we've got to do something different going down the road here, or we're going to have big trouble.
Right. Well, Dr. Applebaum, I can't thank you enough. This is Pam Reese. This has been the most informative session that we could imagine, and it is absolutely going to help us in making decisions moving forward for sure. Thank you so much for joining and presenting to us.
Bob, will we be able to get your slides?
Sure. Who do I send?
Alex. You send them to Alex.
Okay. Yeah, I'll send you the slides, and we do have a number of other resources that might be of use to you. We did a survey of nursing homes and RCFs, and we did have a special memory care focus, and so that might be of interest to you. And then we have a number of other reports as well. So feel free to go to our Scripps website, but I'll send these slides. And again, if you have further questions, feel free to reach out. I'm happy to help in any way we can.
Thank you so much.
Okay. Take care. Good luck.
Yes. Alex?
Yes, Pam, thank you. And Dr. Applebaum, thank you so much for your thorough presentation. Our next presenter is Eric Van Vlymen. Mr. Van Vlymen is the current director of Region 10 of the Alzheimer's Association. That encompasses the states of Ohio, Michigan, and West Virginia. Mr. Van Vlymen also has experience running the Miami Valley chapter of the Alzheimer's Association as well. And I did not know this until recently, but I believe, Mr. Van Vlymen, you are also a professor at Cedarville University. And so without further ado, we would like to welcome Eric Van Vlymen as our next presenter.
Well, if I can just figure out the mute button, we'll be all good. So, well, thank you. And yeah, I adjuncted on a program in Cedarville on social work and aging, and I have been involved in this. I've known Bev Lauer for many years. I was an ombudsman back in the early days. That was my first start out of this. So I've been around this field for over 25 years and have seen just incredible change in the whole field. And then been in the Alzheimer's area. I've been with the association now over 20 years this year, and started out in the program area doing a lot of training in facilities and out in the community. And then just over time, taking on more responsibility. But I'm honored to be here with you. Thank you for the time that you all are putting forth as in the task force. And I know that you have a very short time frame to turn around. And so what I'd like to do today is share with all of you the Alzheimer's Association and where we're at, what we're working on, and also where we're going. And in terms of helping you think through some of the issues as you're making decisions on how we move forward as a state and what we can do as we go through that. So I'm going to break it down. I'll talk about our vision and mission just so you have that out in front of you. But I'm going to break it down in terms of 3 different groups. One is our community and caregivers, so just general community focus on caregivers, talking about long-term care, particularly the staff training and those areas that we've been involved in and how we're there now. And then just senior 65 plus, and we're going to talk a little bit in terms of early detection and some of that. So, our overall, and I'm sure that there's probably no one on the task force who's either gone through this personally or watched so many people suffer over the years, both the person with the disease and the caregivers. But our goal someday is to see a world without Alzheimer's. We have added recently into both our vision and mission the phrase "and all other dementias." So many people assume that we will only help people if they have Alzheimer's, but we really do look at and help so many people with so many different reasons that they come of a dementia diagnosis, and we'll connect them to the resources necessary. In terms of our mission, we're working to lead the way to end Alzheimer's and focus on some key areas in that. One is global research, driving that. And you guys are somewhat familiar maybe with that work. Driving risk reduction. I'm not going to get into that heavily, but as studies and research comes out more around that area, the U.S. Pointer study being one of the largest, more will come as we move forward and advance the science with more clinical understanding. And then early detection, which we will touch on, and then as well as maximizing quality care and support. And that's been the care and support side. We've been known for that for a long time. We continue in that, but want to give you a sense of kind of where we are and where we're going with that. So if you think of the association, there's two things on our mind when we think about our strategies to engage, with now almost 6 million people with the disease in Ohio, 220,000, around 600,000 plus caregivers then caring for them just more directly, not to mention all the families. There's two things that we're looking at. Number one, and this is more on the care and support side, but number one is how do we dramatically serve more people? So when we took a look at our services and what we were doing, we've done a great job of helping people who've come through, service them through care consultations, other things, a lot more one-on-one kind of things. And so we're trying to figure out how do we maximize care and support and drive to significantly increasing the number of people. So I'll talk a little bit more about that. And then the other is dramatically increasing the timeliness and accuracy of diagnosis. So as I talk about these different areas of community and caregivers, the long-term care area, and then in particular just senior 65 plus, happy to go in whatever direction if you have questions, but I'll give you a general sense of it. But those two areas are really key for us and where we're going and how we're doing that. So we know that of the 220,000 people, about 30% of people with dementia live in a facility of some sort, and about 70% live in the community. And so, I just heard Bob's presentation. I've heard before and seen this data, and it's amazing what Ohio has done collectively when we set our mind to it. And so, we know that there's a lot of people in facilities, but we have so many people receiving home care now, and taking care of those caregivers, helping them, giving them support along the way is really essential. So starting there, break that up in a couple different areas. Number one is around education, support groups, and early stage. So the Alzheimer's Association, in terms of addressing our caregivers and the community, we have education, we have support groups. We this year have done over 1,000 programs, even during COVID. Attendance sometimes a little different than it used to be. Support groups, we have over 100 support groups across the state and continue. Again, COVID's had big impacts on that. We can talk more about that. And we do have some early stage social engagement work going on throughout the state. Overall, this is individual, so this is not number of service points, but rather individuals served, unique. We served, I'm going to give you kind of a pre-COVID number. To give you a sense of that, we served about 11,500 individuals through this area. I'll talk about INR and CC here in a minute. But anyway, and so we continue to find ways to go out, provide education, do that. Now, the focus here really is on community outreach and caregivers. We have a list of different programs in general, from 10 warning signs, brain health, those kind of things that might go out to the community. But then we have talks on behaviors, communications about the disease, et cetera, to go in deeper as well and provide that to our caregivers throughout the disease process. We have been moving. So in terms of serving people, what we're trying to figure out is how do we serve more, right? So with 220,000 people every year, we're adding more diagnosed individuals. And we know that, we're expecting this number to almost double over the next about 30 to 50 years. We're trying to think through what we need to do to be prepared, since we're still only serving a small slice of the individuals out there impacted. So we, as we're driving that, we've been moving towards a model of utilizing more volunteers, working through what we call community forums, going into communities, having a session, bringing in the community and asking them through a series of questions what's going, looking for people who might want to help. The ambassador, we have a person in Darke County in my territory, and her family went through this. They suffered through it, and her desire is to be the ambassador in her county so that nobody has to go through this alone. Those are the kind of volunteers we're looking for. People who have a sense of ownership of caring about this disease and the services that are available to them, but helping us get and connect to more. And so even with the staff we have, we just are not able to get out fully into all the 88 communities. And so how can we utilize volunteers to help us drive and engage that more? So we'll be working on that as we go. Through COVID, one of the things we've learned is, providing more trainings online to the whole state at a time. We've seen 200, 300, 400 people sometimes. I'll talk about some of the DEI work too that's happening. So the idea is, how do we reach more? And we believe that the core way to maximize that is through volunteers, engaging volunteers in the community, engaging volunteers in diverse communities, et cetera, and trying to drive to that. The second area is around INRs and care consultations. The information referral, most people have a sense of that, calling, finding a support group, getting connected to a care facility, getting connected to resources in their community or funding streams. So the INR piece is an important part of the whole thing. We do that as well as care consultations, where we sit down and meet with the families one-on-one and try to guide them through the process, meeting with them once, twice, or multiple times if needed. We serve there around 12,000 individuals as well. So these are uniquely served individuals. We saw that take a hit initially in COVID, but it's bouncing back up and look like we'll hit COVID, whereas the education and support groups were impacted a lot more with COVID. If you've been in this business, the care consultation is probably the greatest, one of the greatest things people appreciate, but they don't know they need. And so we work with a lot of families. When you mention it, they're like, oh, okay. And afterwards, I've sat and done care consultations, and the people are crying. They're so thankful and relieved. They will look at you when you're done and say, I literally feel like you took a huge a weight off my shoulders. And even though Alex introduced, even though I do a lot of other things and oversee 3 states, I still, because of the program side, I in fact did a care consultation last week. One of my board members who's caregiving for her husband called and was able to do a care consultation with her, and kind of keeps me in touch. And the needs are so great, and this disease is so individualized. We know it follows similar patterns, but man, the families, the amount of support, the care, the resources they have, all of that is so different. And so in care and support, we continue to do that. We're able to offer it through the phone, both nationally. So we have a 24/7 helpline, and we continue to serve people through there. So, one of the things as you look at that, 365. I mean, it doesn't stop on the holidays. We never shut down our 24/7 helpline. So families can reach us anytime, day or night, anytime, holidays, weekends. And we were surprised. I remember years ago when we brought this on, one of my caregivers said, nobody will call at night, and you cannot believe the amount of calls that we get at night, usually very desperate nights, weekends, and so we continue to offer and provide that service 24/7. On top of that, with some of the state funds that we have, we're able to still do local care consultations. So we still have about 8 staff across the state who can zero in and focus on this and meeting with people back, someday when we're able to do that, but still handled mostly through the phone right now during the COVID time. So in terms of community and caregivers, the key for us, the education, really trying to get out, support groups throughout, some early stage and engagement that we do, and then INR and CCs really driving to helping people through that 24/7 helpline and local support and services. And through the partnership with the state that we have, we're able to provide, I think, a lot more than we could, without that partnership. And so it's really been an effective means for us to reach out and help. The second area is around long-term care. So we used to do more in this area, one-on-ones, going out in facilities, doing trainings. What we found over time is so many of the facilities had their own trainings developed and built. And so that changed, as well as the state as a partner. When they reclarified the dollars that we were receiving, they clarified that we would focus on community and caregivers, but not long-term care. And so that also changed some of the direction for us, as that was something that we were doing and billing. So with a couple of different things that switched, but as I mentioned, our mission, we're really driving towards maximizing care and support. And so I'll talk about that in a couple different ways. But number one of the things we just released this year, our own online training that comes from the Alzheimer's Association. I'll mention how, but it's evidence-based through the Dementia Care Practice recommendations. And so we will be working to get that out into the communities. But that is one source. Again, it's not the only source, but it's an additional source to push into the long-term care community, more training through online, which so many people can have access to. The second area, though, is the work that we've done around dementia care practice recommendations. So we took all of the best evidence that we could find. This has been reported through a journal, through the Alzheimer's Association journal on Alzheimer's, and have a set of practices, starting with person-centered care as the core model of the program, and then moving around and taking care of everything from things like we know, the activities, behaviors, dealing with staffing, diagnosis, working with the physicians, and it looks at all these areas. It pulls the evidence of what are the best practices of that and lays it out. And I think as the state, looks at the plan and looks at that, one of the things we can do is work with the state in terms of how to utilize that to drive what are the best practices. It's evidence-based, and it's all laid out, all things that we can be sharing with you. We actually did a small pilot of that, started in Dayton, Ohio, and we had a donor who helped us. We're really excited as we drove that. And then we were able to take that beginning, and it got impacted by COVID. But now the DCPR process, where we coach facilities, is being developed. It's happening in Montana and in Washington states. They've been actually accessing dollars through the CMP, the civil monetary penalty monies, through facilities. So this has been at least initially nursing home based, but it's basically where we would work with facilities and do actually coaching on helping them look at what are the best practices, what are their practices, and what they can do to change. And so that is a big area that we're driving. We're hoping to come back into Ohio. CMP in Ohio requires a little bit more data, so we are working on collecting data from the other states, and it's another opportunity that we have, I think, going forward. And then quickly mentioning, I know we don't have tons of time, so Project Echo, this is another tool that we've grown and developed. Project Echo is a peer-based training that is offered, and they use it for a lot of other diseases. We actually have a Project Echo session that we can use with long-term care. And so we've been adding different facilities across the country into that. We actually got some federal dollars and had even more, so we can collect more data on that. But that's been really important. So I will just close up. I know time, and I'm guessing just leaving a few minutes for conversation or questions that you have. The biggest thing I want to talk about too is the senior 65 and plus. What happens when we don't diagnose people? So we know that the disclosure rate for Alzheimer's is right around 50%. So if you can imagine going in and having a diagnosis of cancer, and the disclosure rate is about 95%. Right now in Alzheimer's, it's 50. So we know that half the people don't even get a diagnosis. The other half that do go in and try to get it, almost half of them are not even told of their diagnosis, might even be added in. So we have a lot of people wandering around trying to figure out what's going on, thinking these are just general senior issues, not knowing that it's Alzheimer's. So don't have a lot of time to dig into that and share more details and data on that. The key things we're working on there is our health systems work, which is focused then on early detection, diagnosis, treatment, and care. And just to share kind of an idea of a win, I'll touch on public health and then stop and see if there's any questions. But so we've been working with Lake Health. We are doing the Project Echo as well in this area. And so several of their physician practices, when we talk about health systems, we're really working with health systems that own large practices of physicians and general practitioner physicians. And so we started working with them. They started putting some of their teams through Project Echo. They went through another round, added more, and they were interested in learning more. And so one of the things they thought is, well, let's look at how many people are getting screened. When they pulled the data out of Lake Health, so it's a smaller system up, outside Cleveland, when they pulled and looked at that data, less than 1% of their seniors, 65 and older, had any record of being screened. And so they are working with us, and we're helping them look at that data and then build systems to try to improve both screening, diagnosis, treatment, and then what happens? How do we connect them to the care services once it's done? Some of these families, they get diagnosed, they don't know we exist or other services exist. And so we believe that getting that diagnosis is so crucial, particularly as we look maybe in the future of moving towards treatment. We hope someday, but even until then, we've got to build this system out. I'll just lastly add that we have an entire work now with public health. The BOLD Act was passed last year. $10 million went to fund that. We're asking for another $10 million. And those dollars will essentially begin to pour down into the states, where we can begin to work with our public health friends throughout the state to help us get the message and word out about Alzheimer's. So again, I didn't even get a chance. I want to stop and respect all the time. I know we got a little bit later start, but I didn't even get to mention our DEI work, diversity, equity, inclusion work, which is all intertwined into all of this. That we're doing a talk that we had across my region. Actually, I had almost 400 people attend. Just short of 900 had applied, and I think an additional 150, 200 people have watched that. But so we're beginning to get information out like that, but we also are working on systems to track how we're doing, where we are in those communities, and what we need to do to engage. So I'll stop there. I can see a hand. I don't see any name. So happy to entertain questions here for a few minutes before you guys move on.
I think that hand's probably mine. Doug Beach.
Hey, Doug.
How are you? Couple quick questions. First quick question, is the care consultation, is that BRI's care consultation that's evidence-based, or is it something you guys put together?
It is our own care consultation. We had worked on the BRICC model. For us, we were trying to figure out how we can serve the most people, and that's a pretty intense ongoing process. And right. So we have gone with a model where, we will help people as many times as they call us or need, but at least with the care consultation planning, we'll see them build the plan, follow up on that plan as needed, but not to the extent of the BRICC.
And I appreciate your presentation. You went through a lot of stuff quickly. Very, very interesting. One of my questions is I was with Dr. Boutros, who's president of CEO of Metro Health, and he was suggesting that they've made a lot of progress on the research side of trying to find a cure. Do you have any updates on that?
In general, or
he was talking in general terms. I'm not quite sure what he was saying.
yeah, I think the biggest thing, and Trey, I've been working with Trey and sharing with the director as she leads this, is that we included a presentation actually in our advocacy day last week about this. Did a 30-minute presentation, but I think couple things are really happening here. Is one is we're moving closer towards biomarkers. They actually exist, but more on a research level. Biomarkers are great, but until we have a treatment, it could create more problems than not. You do have aducanumab, who is on tap in June to hear from the FDA whether or not that's going to be approved. There's different beliefs on whether or not that should be. Here's what I can tell you is if it is, it will ultimately change. There's a lot of things that have to happen for us to be prepared. And for us being in the health system side, really driving towards the relationship with the practice, the people who control so many of the practices, is if it is passed, how we provide care for people. If you think about it, once a treatment is available, treatment becomes care. And we've always thought about care as people way, way down the road. Is it going to be aducanumab? I don't know. That'll be the FDA's decision. If it's not that, we are going to get a first drug, I hope, here in the next few years, that's going to open the door for us, answering a lot of questions of moving care and support earlier so we're able to help diagnosis. The thing that we can do as a state to best prepare, regardless, is getting people quality diagnosis. I mentioned this, dramatically increasing the accuracy and timeliness of diagnosis. That we know is not happening. And I'm sure everyone sitting on this panel and across the task force has experienced what happens when these families don't know honestly what they're dealing with and have not been told what they really are facing.
Thank you.
Yeah, absolutely. Other questions?
Hey, Eric, this is Kenny Yuko.
Hey.
With all the activity going on in Washington, D.C. with these CARES Act dollars, are they going to send some money our way so as we prepare for the onslaught of new patients after this pandemic comes to an end a little bit, we can get more involved with the research dollars and programs to address the needs of our families throughout Ohio?
Yeah, that's a great question. So how do we maximize the dollars, right, the federal government spending? There's a couple things, Senator. So, I think one is we have seen federal funding of research, and the association has really worked to drive this, go from about $470 million to we're trying to get over about $3.2 billion. And so I think the biggest thing there is to really work. We have amazing research groups here in Ohio, but you see, and some of the funding has come here, but you see it go into other places as well. So I think it's really taking a look at the research centers that we have and making sure as a state, we just added one of the Alzheimer's disease research centers that's federally funded has come into the Cleveland area. And so it's nice for Ohio to have its own ADR, we call them ADRCs. So it's nice to see that. Those kind of things are great moves for Ohio to attract more of that federal research. And we're not stopping. We believe we need to continue to grow that. We've seen people survive cancer. We've seen people survive a lot of heart things. We know that when you invest in science and research that someday Alzheimer's will get there. So that's one. Two is around this public health area. And again, in all these areas I've touched on, we have people who are far more expert in this that can address the group here if you have interest in it. But around the public health area, the BOLD Act that was passed, we're working on funding an additional $10 million. Doesn't sound like a lot, but we're trying to get that. Those dollars then will be initially moving down into the state. and hopefully as we work with the federal government and basically deriving work for Alzheimer's and awareness and education down, even as a public health response. And so that's another area that the state could take a look at. One of the biggest things that exists now is we had worked and had passed, there's some real issues, so we have to work through it. But another way the state could partner with the federal government is there is funding for a quality diagnostic review that actually includes other parts. It doesn't work in neurology offices or specialist offices. They can't make enough money to make it work, but it was really designed to work in primary care. And through Medicare, it can be billed and driven in. Again, another great way for the state to look at this Medicare funding that's out there, and is there a way that we could help the health systems and the medical practices connect to that? Because it requires a diagnosis to be written in their record. It requires a follow-up care path, and actually then engages the care system. If you have diabetes in Ohio or anywhere in the country, there's actually funding out of Medicare that you get more support and service around that. And with Alzheimer's, you get a diagnosis and that's it. Nobody helps you. It's just sorry to hear, you have Alzheimer's. So there's actually some funding streams. And again, we're happy to help you all in the subcommittee or to the whole task force. We have experts in this working on it, looking at what other states are doing. Whatever we can do to support you guys in this pretty difficult task you have of building this plan over the next few months, happy to do that. But those are just a couple of ideas out there, that things that are coming down, how Ohio can prepare. The one thing I just would say is, I know they had asked Dr. Applebaum last question, in comparison, Ohio has an opportunity because most of the state plans are written, and I know Senator, you had mentioned this, is we might have been the 50th, but we'll have the best one, right? And when we get this plan put together, we have the opportunity, because most of those plans were done 5-10 years ago. Science has evolved so fast and furiously. So Ohio has the opportunity to look ahead of where we're going and actually build a plan for that. But we can't do it on the cost of forgetting about our 600,000 caregivers, 200,000 people with the disease. So we have to continue to provide that support in the community and in facilities, but we do have a great opportunity as well to look ahead.
Perfect.
Thank you.
Does anyone else have any other questions?
Yeah, Eric, this is Beth. I just wondered, can you say a little bit more about what your plan is for your CMP project for nursing homes?
Yeah, so the dementia care practice recommendations, what we started, I think, in pilot in Ohio, was it's basically like a coaching. So we would partner with facilities. So what's happening, and again, I can provide additional if you guys would like to see, but so we have, basically, we kind of took this coaching and built it, and then we're doing this with Montana and Washington. So we'd partner with a facility. They would take an area, it's pretty massive. So trying to get them to look at everything all at once, but they might pick coming at different modules. And then they would begin to self-assess and work to see what they need to do to drive better systems. Having done training over the years, I love it. I love training. I've gone in, I've trained thousands of staff, but you go in and you leave and their systems aren't always set up right, and this being in your role. And so how do we change the system? How do we maximize care and support? So we've taken an approach of here are the best practices. How do we get people to align? So it would be a pilot, or it'd be a project very much like that with the CMP. Again, they wanted a little bit more data, so we're working in these other states to pull data. We're working, I think, to move towards a third state, so that we can kind of provide a little bit more evidence on how it's working. And then we'll come back to Ohio with that evidence and be making a proposal. But it's really about coaching facilities. Of course, with CMP money, it has to be long-term, it has to be nursing homes.
Nursing homes only,
So,
right?
So that's where the focus is. But again, able to and have experts who help build and lead that but happy to have a deeper conversation around the dementia care practice recommendations and how you guys could utilize them to drive quality in terms of what's expected and what should be out there based on the evidence.
Great, thank you.
Sure.
Well, Eric, I can't thank you enough. It's been great information, and I feel like we will be reaching out to you again.
However, yes.
To obtain additional information and to help our committee to provide the best experiences and understanding a little better about the gold standards that already exist.
Yeah, happy to do that. So please let me know. And then we had a lot of what I kind of pulled out was based on a lot of facts and figures we publish every year with special reports. This year was focused on diversity. We've done it on diagnosis and physicians. And so a lot of I've touched, so any of that data you guys need, happy to package and get it to you in a way that's useful. So let me know. I can, hit a presentation just on that data specifically.
Thank you so much.
Thank you. Thanks for your work.
Thank you. Alex?
Thank you, Pam. And Mr. Van Vlymen, thank you so much for joining us today. Really appreciate your time. Our next presenter is Rick Hoover. Mr. Hoover is with the Ohio Department of Health. He is the Survey Operations Administrator. And so without further ado, in the interest of time, I'd like to introduce Mr. Rick Hoover. Thank you.
Thanks, Alex. I appreciate it. Yeah, I'm Rick Hoover. I'm a registered nurse with the Ohio Department of Health, and I've been with the Bureau of Survey and Certification for 15 years now. I was asked by the committee to report on state and federal regulations that are currently in effect for residential care facilities and then nursing homes. What I think it's important for the committee to know is that if we're talking, the state requirements versus a federal requirement, both of these kind of lead you to believe it's really up to the provider themselves on what type of training to offer their staff. There is no standard training, like if the Alzheimer's Association, if they had an excellent training out there, we may see that in one of these homes, and then not such a good training in another one when we go out to do our inspections. So for the, and I'll start, residential care facility, then we'll talk nursing home state, and then we'll talk nursing homes on the federal side. So with residential care facilities, the requirement that's currently written is if a residential care facility admits somebody with a cognitive impairment, they have to provide 2 hours of training to their staff member within the 14 days of orientation. Again, so it's very vague. There's no specific. It needs to be conducted by a qualified person, and outside of that, it could be a training across the board, whatever the provider is using. And then annual training for these individuals, you would want to see 4 hours if they're in a cognitive impairment unit, secured unit, dementia unit, whatever the case may be. They get 4 hours of annual training. You will not find that requirement on the nursing home side, and the reason for this is there's a state tested nursing assistant training that you need to complete to work in a nursing home versus working in a residential care facility. And then to Dr. Applebaum's point that he's talked earlier, when I first started with the department, there were probably less than 200 assisted living facilities, and right now we have over 750. So that provider type has grown tremendously over the past 15 years, and just in what we're seeing. And a lot of these residential care facilities do have a dementia unit, a secured unit in their facility. And I also think it's important to know for the committee that with these individual facility types, even though you may have the true assisted living side and then your secured unit side, they still fall under one license number. So just because I'm going to say I'm going to hold myself out as a dementia specialist or a secured unit environment for individuals with cognitive impairment, there's really no additional process for them to go through for a license. So once they're licensed as a residential care facility, they can choose to operate in that manner. With, of course, they have to have the additional training for some of their staff members. So that's on the residential care facility side for state requirements. And then for the nursing home side, the requirement that you'll see written is that staff members receive orientation and training to perform their job responsibilities. So then again, a very generalized statement on what needs to happen for these individuals. And then they need to have routine in-service education for these nurse aides, state tested nurse aides who are working on these specialty units. So if a nursing home holds themselves out as having a specialty unit, such as a dementia unit or cognitive impairment unit, they need to have routine in-service training for those individuals as well. Again, there's no standard in that training. It could come from a number of areas. And we do see that when we go out to do survey inspections that, some trainings are ultimately better than others and presented to staff better than others that we find out. So that is on the state side requirements for nursing homes and what training needs to occur for them. And then also, since nursing homes are state licensed and then also federally certified entities, there's federal requirements that nursing homes have to follow as well. So the federal requirements are, again, very generalized. It says that staff need to have sufficient training and they need to assure the safety and maintain the highest practical physical, mental, and psychosocial well-being of the residents. Very generalized statement. It's really a global, you need to take care of your individuals in your home. You need to have sufficient training of your staff to do so. But again, there's no specific standard to point to that you must have these individual tiers of training. CMS, within the past 5 years has issued guidance to nursing homes. They've issued training modules. There's been really no specific requirement to make them do that. There's the latest training that CMS put out was the hand-in-hand model. They sent this training to all the nursing homes in the state and across the country to offer for their staff to have this training, but there's nothing written in the federal requirement that says you must specifically do this training. They can get this training, from whatever source that they're getting their trainings through now. A facility must also provide a dementia treatment and services to the residents. So again, generalized statement, really what that means is that if you have a resident with a cognitive impairment, you must provide those services to them, which partially meaning staff are qualified to care for those individuals. And then also with the federal requirement, since it's a federal requirement to be a state tested nursing assistant in the nursing home, there's specific nurse aid training. But it's a generalized statement again. It must be sufficient to ensure competence, and that's what it says on the federal requirement. So really, what does that mean? So annually or quarterly, whatever the home deems appropriate, they need to evaluate their staff. They need to make sure that their staff members are competent to care for individuals, especially on these specialty units. So are they interacting appropriately with that specific resident population? If not, what training do they need to get there? And that would be a requirement on the facility to complete. In both areas and across all three regulation sets, so your state license for your residential care facility, your nursing home state license, and your nursing home certification, all states that annually these individuals who are direct care providers need to have 12 hours of training. And then on the state side, we say you need to have 4 hours specific to that specialized unit, which the CMS requirement is specific to their job role or title, and then it doesn't give a specific number of hours these individuals have to complete. I also want to point out, as part of to become an STNA, a state tested nursing assistant, you need to take a state course, and it's the requirements are given to us by CMS, and then we had our state licensure requirements on top of that. You need to take a state course first, and then you need to pass the state test, and this is only to work in a nursing home. But as part of that curriculum for that state test nursing requirement, there's some general areas that I pulled out that would be specific to dementia training that I'll share with the committee as well. So one of those is work environment. So if you are working in a home or that has a secured unit, a dementia unit, what would that unit look like? So, are there additional staff requirements for that? Typically there are locked doors, or they're usually either like a Wonder Guard protected, or you have to punch in a code. So specific to this environment, you would want to train your prospective nurse aides on, what type of environment you're going to be on. Communication techniques. Some of these residents that we're dealing with in nursing homes may be nonverbal. So what are some of the nonverbal cues that you could look for to see if an individual is frustrated or agitated, and what works best for them to de-escalate that situation at that point in time. General safety practices and procedures. This population, you may have individuals who like to walk and walk a lot. So is this a safety issue for them? Is that why they need to be on that secure unit? Do we need to keep an extra set of eyes on these individuals to make sure they stay safe? So that would be general safety practices and procedures that these nurse aides would need to be trained on as part of that their program there. Assistance with meals. Can these individuals feed themselves? So these STNAs will be trained on, how to appropriately, assist a resident with eating. Sexuality and aging is a part of the curriculum. So, so some of these individuals, you may see some hypersexualism. How do we de-escalate that? And then just generalized care with residents with dementia. So what does this progression look like? How do we deal with these individuals? How do we, get appropriate training to understand the complexities that we're seeing there? So these are some of the nurse aid training topics that's already currently in the curriculum for providers to use for that. So that, again, there's only really generally 3 requirements for training of the staff. You'll see 2 of them are associated with state licensure, one for residential care, one for nursing homes. And then we have some of the federal requirements that you've seen that would be specific to the nursing home itself. So I'm available for questions if you have any questions on the training requirements.
What's the cost of the training?
For the nurse aid training?
Yeah.
So nurse aid training, we do not regulate the cost that's put on the individuals to take the training. You will find a wide range of cost to the individual. Some are free. Some, I'd say probably the typical amount is maybe $300 to $500 that we'll see for this training. The training itself is a 2-week training. It's a 75-hour course at minimum. It can be longer. That would be at the discretion of the training site itself.
And do many employers pay for that training, or is it almost, if it's not free, almost always out of the pocket of the individual?
So the individual, if they pay out of pocket, and there's a federal requirement that says that if you seek employment of a nursing home, I believe it's within the first 48 months, it may be 24. I'd have to get a specific requirement for that. But they could seek reimbursement from the nursing home themselves. So there is some cost reporting that's through the Department of Medicaid that they could request that reimbursement for them.
Yeah, thank you.
Yes.
Any other questions for Rick? Well, Rick, you gave us what we needed to know about education.
Yes, ma'am. All right, thank you very much.
Thank you so much for joining us and letting us have that information. And obviously, would you say, Rick, that this is a need to improve that education for the caregivers or the employees of memory cares? And
so far, as part of survey, and again, some trainings are excellent, but some trainings are not. And there's no specific in either requirements on the state or federal side of a basic building block of training. So that's what I would like for you as the committee to understand, that if you were to go down that route of training and education, that would be something, in my opinion, that could be needed for the future development of these individuals.
May I ask a question, Rick?
Oh,
do you, in the course of looking at the statistics, do you have any indication of the level of turnover in the nursing aid positions, and how easy or difficult it is for a residential care facility or nursing home facility to keep staffed trained employees?
I don't have specific numbers, but it's been my observation through working in this industry that there's high turnover everywhere in these facility types. Whether you talk administration down to the direct care level, there's a high turnover.
And is that high turnover, do you have and I apologize, I may have missed what you just said, but is that related to primarily pay, or is it primarily job duties?
I wouldn't say there's one specific reason. I would say, it is a stressful environment for individuals to be a caregiver. I would say that plays a significant factor in it, but I wouldn't say that's the only factor. Ultimately, especially for our direct care staff, they're likely paid the least in these facilities, but really they do the most work. So your STNAs, are doing all of that patient care. And not to say that the nursing staff doesn't help, but you generally see your STNAs doing the majority of the work with these residents.
Thank you.
Yes, ma'am.
Rick, Diane Kanka, quick question. Do you see any difference between private facilities and nonprofit facilities in terms of either staff turnover or training or salaries?
I don't want to speak for the nonprofits versus the for-profit facilities, and I don't have the stats to give you on that. And I just from working in the industry, I will say that probably the not-for-profits, I think they may pay a little bit more, but I don't know that to be true now. It's been several years since I worked in the nursing home, but
sure. Thanks.
Anything else from anyone? Hey, Rick, thank you so much for joining us today.
Yes, ma'am. Thank you very much.
Yes. So we've reached the end of our time. And I just wanted to briefly mention that I had sent an attachment where I broke down the task. And I hope you can understand what I was trying to do there was I took our tasks, sectioned them out according to those that we have to require or seek information so that we can create action steps to the remainders. So I think today was very, very good. I want to be able to move forward with narratives and how that will play out. The groups we're going to talk to would love to get that in place for May. And then hopefully by June, we'll be able to assimilate all of our information and make some decisions. Does anyone have any questions about any of that?
Pam, this is Jennifer.
Yeah.
I've talked with the Alzheimer's Association about helping us to identify persons living with the disease and caregivers to provide narratives. So if we want to do that in May, I'm happy to, at least in those two constituents, go to the Alzheimer's Association for help.
I would love that. Thank you so much. And anyone,
I'm not sure what you mean by narratives. Can you?
Sure. So in the description of our project is to obtain real information from those caregivers. What do they need? To listen to their voice, as well as a couple providers, maybe gerontologists, first responders, and folks that may have just been diagnosed with Alzheimer's or dementia. And
so based on the conversation we had with Rick, then are we going to ask for state tested nursing assistants as well?
I think that would be a great idea.
Okay.
To and get their input. And I think this is really going to help us listen to the voices of the caregivers, the staff, even if we could hear the voice of some residents or patients or those diagnosed, I think that will really help us move forward. So I hope to get out, maybe I'll send out emails or just some thoughts of questions that would be good for us to ask and how we can proceed with those meetings. So with that said, Alex, help me out with adjournment of the meeting.
Actually, Pam, one little thing.
Good, Diane, I'm sorry.
I'm sorry. I just wanted to mention that, Pam, to you and to Alex, I found the 2020 AARP LTSS scorecard, downloaded it and sent it to you and to Alex, so for Alex to distribute, because I didn't have everybody's email address at my fingertips. And then also, in the information that you send out to us, Pam, will you therefore include information on how we can bring people in to actually sign up for sharing their experiences? I have 2 AARP volunteers who are both advocacy volunteers who have expressed an interest. One had a mother who had Lewy body dementia, and the had a dad who had Alzheimer's. So, firsthand caregiver experience.
That would be perfect.
Good.
That is perfect. Thank you so much for that.
Thank you.
Can I make a suggestion? I have a question. This is Melissa. Sorry, I couldn't attend the last time, and so maybe you guys already discussed this with regards to the narratives, but in order to hear from as many people as possible, given our time constraints, is there any thought or feedback regarding doing like some sort of online survey? We could have a link on the website with just general, questions and comments. I realize maybe some of the people that would be participating may not have access to the internet or things like that, but I feel like it could, if we use like Google Forms, like that survey site, we can really digest the information on perhaps more people than if we just constrain the narratives to those we can hear from during our meeting.
I love that idea, Melissa.
I'd be happy to do that.
Would you?
Yes, I'm not going to be able to get to it until May. I start a murder trial tomorrow, so
May,
but it shouldn't take that long at all.
Okay.
Not even a day.
That's perfect. And like I said, we're going to have to suggest questions. What's relevant to this committee? So, anything else? So we have our full committee meeting, I believe, next Monday. And then we will have to schedule another meeting for us. Do we want to do that now, or should we circulate emails?
Did we agree earlier on the 1st and 3rd?
Did we?
Monday of the month? I thought we had, but maybe I was wrong.
Could be right. And I'll talk to Tessie about that as well. All right, I think we did it. Today was wonderful. So with all that said, Alex, do I just adjourn the meeting?
I would only ask that there be a motion from a member of the committee in order to proceed with adjournment.
So moved. Deb Laubert.
Second, Melissa Schiffel.
Are there any objections to the motion? Hearing none, the meeting stands as approved, or it stands adjourned. Thanks, everyone.
Thanks.
Appreciate it.
Bye-bye.
Bye-bye.